Good morning, everyone. Today's topic of discussion is scrub typhus. It is another uncommon disease which was not priority for us for the discussion, but nowadays so many cases are reported from different sides of our country, and that's why we are being so much giving importance to this topic. And this topic is more important for yours because the disease is more endemic in your district also. In Bankura, so many cases are reported since last 2 to 5 years from different side of the Bankura. So you have to know the common features, common clinical presentation of the disease. So myself, Dr. Rajib Saha, now I am starting the scrub typhus in details. The disease was first identified in 1930 in Japan. It actually caused by the intracellular parasite that is called Orientia susugamosi. From name you can think that it's originated from the Japan, or first they identified in this country. It belongs to the Rickettsia family. Usually, the most of the cases of the scrub typhus is noted from this part of the world. This part is called the Susugamosi triangle. The boundary of the triangle is one side Pakistan and Afghanistan, another side is northern Japan to far eastern Russia, and another side is the northern Australia. This is called the Susugamosi triangle. All people belonging to that area is susceptible for the disease. Usually the disease is reservoir, the rat act as the reservoir for the disease, and the disease transmitted through the trombiculate mite, and that is very microscopic size, and it's not usually seen in the open eyes. It's very difficult to see, and all the population are susceptible for the disease from child to adults, and mainly the cases are reported from the countries of the Susugamosi triangle. So how the disease is transmitted actually? Usually the disease is transmitted among the rodents, and accidentally the other animals and humans may be infected, and very rare cases found from person to person transmission. Most of the cases the accidental transmission from mite to from rodent to other animal to humans. And now I am coming to the next topic, and that is mode of transmission. Usually when the larva of the mites develop from the eggs in the wet season, that may infect the vertebrate host. So from the previous slide you can see that usually the triggers or the trombiculate mite present within the body of the rodents or mites. So within the body they develop from the stage larva to nymph and adult, and within the adult form they lays the eggs, and that eggs may be infected the vegetables or soils, and from the eggs they form the larva. That larval stage of the trombiculate mite is the infective stage, and they carry the infection Oriental Susugamosi from rodent to accidentally to human if they touch that surfaces, which surface will be, suppose maybe vegetables, maybe any surface which is infected by the rodents carrying the infected larva mites, and that larva mites lay their eggs on that surface, and they transform to the larva on that surface. And as I have told that the size of the mite is very, very microscopic, So we can't assume when the infected larva mites coming to our body. So in that way, usually transmission occurs. Just see the cycle from eggs to larva to nymph and adults. Here the picture will be more clear here. Normally the larva feeds on small mammals and ground-feeding birds. So within the body of rat, the infected larva growing up from the engorged larva to nymph stage and from the adult stage, and in the adult stage they lay eggs. Transovarial transmission of the rickettsial bacteria, gram-negative bacteria occurs. Through eggs it transmitted to the next generation, and that next generation larva causing the source of infection for the other animals or humans. So in that way the disease is transmitted from rodent family to the other family. So microbiological aspect, the scab typhus is caused by Orientation susugamisi. I have already told. It's a gram-negative bacteria form of family of Rickettsia. And it's mainly transmitted through the infective stage of larva of termites mite. It carries the Orientation susugamisi, and it is an intracellular pathogen actually. And many antigen strains have been identified over the years. From the original three strains are Carp, Captain and Gilliam. These are the common strain, but besides that many strains were identified. Infection with one strain of the pathogen does not provide immunity to the other strain. That's why the infection may happen multiple times. So it is already discussed. These are the hosts. Usually the susugamisi transmitted among the rodents. From the rodent, it may accidentally transmit the other animals, and from other animals' body to human, or directly to the human it may come. So what actually occurs? First, when enters the bacteria within our body, so it multiplies and causes the bacteremia, and its proliferation on the endothelium of small blood vessels causing the release of cytokines. These cytokines cause the damage of endothelial integrity and fluid leakage through that damaged endothelial layer, and sometimes platelet aggregated, and polymorphic monocytic infiltration was also seen. Due to the platelet aggregation, microvasculitis may be seen that causes the focal occlusive and characteristic. This microinfarct may lead to the organ failure. That is the main pathology actually. The first, the bacteria multiplied within our body, and this proliferation of bacteremia causes the release of cytokines and causing the damage of endothelial layer, that causing the fluid leakage, and endothelial layer, damaged endothelial layer attract the platelet aggregation, increase the process of platelet aggregation, and also increase the infiltration of polymorphic monocytic cells, and that collectively cause the focal occlusion of the end arteries, and that ultimately lead to the microinfarct and cause the reduced blood supply of the vital organs, and organ go to the failure. What is the common clinical features? The common clinical features for the all rickettsial infections is like that usually undifferentiated fever for more than 5 days. Sepsis of unclear etiology. Sometimes may present with the fever with rash, fever with edema, dengue-like disease, fever with headache and myalgia, fever with hepatosplenomegaly or lymphadenopathy, sometimes aseptic meningitis, meningoencephalitis, acute encephalitis syndrome, sometimes fever with cough, pulmonary infiltrates or community acquired pneumonia, sometimes fever with acute kidney disease, sometimes fever with acute gastrointestinal or hepatic involvement. So if you gone through the list, you can see that the symptoms are more or like the other viral illness, viral fever like illness, but when the specific organ is being involved due to the end arteritis, that specific organ related symptoms will be occurred. If it involve the lungs, it looked like a symptom of the pneumonitis. If involve the heart, the symptoms like the myocarditis. If involve the meninges, it symptom like the meningitis. And if involve the kidney, it shows the symptom like the acute kidney injury. So usually the incubation period is 6 to 21 days, and they presented mainly the high grade of fever, 104 to 105 degree Fahrenheit, and with chills, malaise, conjunctival irritation, maculopapular rash, lymphadenopathy, lymphocytosis, sometimes headache, cough, myalgia, and gastrointestinal symptoms. These are the common virological fever symptoms where the headache, cough, myalgia present, and conjunctival irritation present, lymphadenopathy may be present. But the most important features, and that is called the pathognomic features, or make say that the diagnostic feature also. On the 5th day of illness, in 60% cases, eschar formed. What is the eschar actually? How it looks like? It will be discussed in next slide. Usually, within the incubation period, when the symptoms develop, the first symptom will be the fever, and the symptoms like a toxic symptom due to the release of cytokines. So the toxic symptoms mainly appear in the first week. The result of the release of cytokines due to development of the microarteritis, and the second week the symptoms become worse and complications may develop. On the third week, if patient recover, then go into the convalescence phase. So how the eschar looks like, that is the more specific manifestation. In case of 60% cases, it is found in the body. Usually the axillary fossa, inguinal region, perianal region, scrotum, buttocks, and the thighs, mainly within the folds of the skin. The maximum cases eschar are found. So it is very maybe unnoticed by the patient also. So you have to search any eschar is present within the body or not if any patient come with a history of more than 7 days of fever. So appearance of the eschar is ulcer surrounded by a red areola, is often covered by a dark scab. So you can see within the picture how it looks like. This is eschar. The usual distribution of the eschar I have already told. So just see the picture from head, neck, face, axilla, genitalia, inguinal region, buttock, lower extremity, chest, or upper extremity. Everywhere it may be distributed, but the most common site is the genitalia, inguinal region, or buttock, and axilla. Within the folds, the most commonly it has found. This is another picture of the eschar. So what complication occurs? If you can remember the pathogenesis of the disease, then you can say the complications. Due to the development of the microinfarct, due to the endarteritis symptoms, so all the organ which will be involved, the symptoms will be like that. I am repeating the symptoms and complications again. It might be pneumonitis, might be hepatitis, might be myocarditis, might be meningoencephalitis, disseminated intravascular coagulation develop in the later stage, and ultimately lead to the multi-organ failure and ultimately death. So patient may be present with a single symptom involvement, just like the pneumonitis only hepatitis, only myocarditis, but may be present with all the complications together. How along the human body is being infected or being involved due to the inherited symptoms. In that way, the complication will develop. If you go into the lab findings, the total leukocyte count will show either normal or low. If going to the differential count, lymphocytosis may be present in the later stage. In platelet count show the thrombocytopenia. Due to the release of cytokines, ESR and CRP will be high. Sodium and albumin slightly lower side. Liver enzymes will be raised if it involved. And if the symptoms of meningitis is present, the CSF show the pilocytosis. And if the lung involved, the patchy pneumonitis will be shown in the chest X-ray or CT scan. This is the algorithm how we will approach actually. When patient come with a compatible clinical scenario and have some suggestive epidemiological features and absence of definite alternative diagnosis. What that means actually? The compatible clinical scenario means the high rise of fever, that is 104 to 105 degree, that presenting more than 7 days. And patient is coming from a geographical area where the disease is endemic. Then you have to suspect the case might be scalp typhus. And absence of definite alternate diagnosis. So within the first week you have to suspect the case of high rise of temperature. You have to rule out the malaria, dengue, typhoid. If the all common febrile illness is excluded, then you have to suspect the scalp typhus if the patient comes from the endemic geographical area. So after when you suspect the case as a scalp typhus, then you have to search for the eschar. Is eschar present in not within the body? Usually it is found in the folds of the skin, in the groin regions, the axillary regions. If the eschar found, and then you go for the some suggestive laboratory test, and just like the oil-Felix test or ELISA, if patient is suffering for more than 7 days, if both tests show the positive result, then you can say the case is positive, probable case. Because the oil-Felix test and ELISA is used for the screening purpose, their sensitivity is poor. So the positive result within the oil-Felix test and ELISA test is not confirmatory. It helps to suspect in the cases as a probable case. If a patient coming with the same symptoms and going to the empirical therapy of doxycycline more than 48 hours and patient fever subsided, that means the deferred presence. So deferred presence means the when patient fever subsided after if the patient fever subsided after getting the doxycycline therapy for 48 hours and shows the oil-Felix test positive, ELISA test positive, or eschar present, then you can suspect the case as a probable case. So when you can say a case confirmed case, that any confirmed case must be confirmed by laboratory. Within the 7 days of illness, if polymerase chain reaction test show positive, obviously it is the confirmatory case and it diagnoses the case confirmably. But if patient presented after the 7 days, we can do the indirect immunofluorescence assay or indirect immunoperoxidase assay. And if those tests show the positive result, then we can also say that the cases are confirmed case. Whatever the case, either it's a probable case or confirmed case, you must going through the common antirictual antibiotic protocol and also give the supportive therapy to limit the complications. That is the actual algorithm how to approach to the patients. So now I am coming to the details of investigations. I have already told the available investigations are oil-Felix test, indirect immunofluorescence test, indirect immunoperoxidase test, and PCR. Usually the blood sample of the feverish patient is used for that. In some research it is said that the specimen which is obtained from the eschars that might be show positive result in case of polymerase chain reaction. Oil-Felix test is very cheapest, most easily available, and it can be used as a screening test but not the confirmatory test, because its sensitivity is very pure, near about 40 to 50%, and is not reliable. But the gold standard is the indirect immunofluorescence test, but it needs the fluorescent microscopy, that is costlier, and sometimes it needs a expertized laboratory technician to elicit the result. So when we setting the immunofluorescent microscope is not present or efficient staff is not present, then we can use the other test, that is the indirect immunoperoxidase test, and it is comparable to the immunofluorescent assay. And if we get the positive result through the immunoperoxidase assay, we can say the test is confirmed. So olfactory test, you have already read in the microbiology lectures that basic of the olfactory test is that some common antigen is shared by both Rickettsia and Proteus. Here we are using the some Proteus strain, just like OX19, OX2, OXK. When it shows the positivity with the OXK, then we have to suspect as a case, maybe a case of scrub typhus. Regarding the polymerase chain reaction, it is a more specific test and rapid and specific diagnostic test. It can be used to detect the rickettsia DNA in whole blood or Asst samples. Some journals are nowadays reporting that the Asst samples may show the PCR positive, and within the 7 days it shows the positive result actually. And I have already told the other gold standard name of the other gold standard test, that is the indirect immunofluorescence assay, and it is usually recommended only for research and area where the seroprevalence of rickettsial disease has been established, and where the fluorescent microscopy is present and the expertized manpower is present. If the expertized manpower and fluorescent microscopy is not present, then in that case indirect immunoperoxidase assay can be used. We do not recommend any rapid test for diagnosis of scrub typhus at the present stage of development, and we always recommend the PCR for the confirmation, after the 7 days immunofluorescence assay or indirect immunoperoxidase assay. IgM and IgG ELISA technique, particularly immunoglobulin M capture assay for serum, are probably most sensitive tests available for rickettsial diagnosis. And the presence of IgM antibody indicates comparative recent infection with rickettsial disease, and usually IgM developed at the end of first week, and where IgG developed after the end of the second week. So you have to keep in mind when you are writing the prescription for the fever risk patient, if patient come after the 7 days in the just end of the first week, then you have to prescribe for the IgM ELISA, not the IgG ELISA. If patient come after end of the second week, then you can prescribe IgG ELISA. So what is the treatment? Treatment must be initiated with the empirical antibiotics. If patient shows the response, whatever the result, you should not discontinue the antibiotic. It should complete the course actually. And if we going through the treatment schedule, the treatment schedule is a doxycycline should be given 100 mg twice daily for 7 days. Any adult patient whose weight more than 45 kg, and they must be prescribed the doxycycline 100 mg twice daily for 7 days. Either you can use the azithromycin 500 mg single dose for 5 days. In case of children, the dose of doxycycline is 4.5 mg per kg per body weight per day in 2 divided doses and for 7 days. And if you prescribe the azithromycin, that dose should be 10 mg per kg body weight single dose for 5 days. In case of pregnant women, you have to prescribe azithromycin as a drug, class of drug. Doxycycline is contraindicated in pregnancy. So dose is same, 500 mg single dose for 5 days. In the secondary and tertiary care level, where the uncomplicated cases are come, you have to follow the same treatment protocol. But if the cases are complicated, all of you know that in the second week, patient going into the complicated due to the plasma leakage and forming of the platelet aggregation and microinfarction involvement of different organs. Then you have to start the treatment with the intravenous doxycycline, that is the 100 mg twice daily in 100 ml normal saline to be administered as infusion over half an hour. And the dose, if patients respond well, then you have to switch over to the oral therapy and complete the course up to 7 to 15 days according to the response of the patient. If you start the treatment with the intravenous azithromycin, the dose should be 500 mg diluted in 250 ml normal saline, and it should be transfused over 1 hour, and it should be given once daily. It can be given 1 or 2 days, then followed by you have to switch over to oral therapy if patient is recovering, and complete the course within the 5 days. If you choose the intravenous chloramphenicol, the dose should be 50 to 100 mg per kg per day, 6 hourly dose, and administered as infusion over 1 hour initially, followed by oral therapy, and that should be completed 7 to 15 days. So available treatment options are doxycycline, either doxycycline or azithromycin or chloramphenicol. It is seen that the doxycycline and chloramphenicol resistant strains are being noted from the Southeast Asia, and in the areas azithromycin sensitivity is very good. So you have the three options of the treatment you can use according to the sensitivity result. So the disease might have more complication. It may lead to the death too, if severity developed when the multiple organs being involved. But the disease is very much good response to the antibiotic treatment. If the disease can be identified within the earliest time, then you can get the good result. You can limit the complication, development the complication. So usually within the 7 days, it's very difficult to suspect it as a scalp typhus. But when a patient presenting with fever more than 7 days, you must go through the appropriate laboratory test to confirm the diagnosis, is it scalp typhus or not. And if you start the doxycycline or azithromycin or chloramphenicol, within 1 or 2 days it shows the drastic improvement, and it can limit the development of the complications. So early diagnosis is the most important part to limit the complications. If you go into the prevention part, you have to use some the insecticide for the vector control, that's like linden or cloden to ground and vegetation. Usually you know that rodents act as a reservoir, and within the reservoir body they lay the eggs, the mites. From the rodent's body it may transmit it to the vegetables or ground level. When the farmers are handling those vegetables, it accidentally be infected through the eggs or larval stage of the termicoid mite, which are carrying the rickettsia. So then you have to control the environment, and then who are working on the field, they must wear the full sleeve clothes and wash their hands properly to limit the transmission chain actually. So in that way you can prevent actually the disease. So what is the most important key point? Acute febrile illness caused by Orientia susugamosi and spread by the bite of the larval form of termicoid mite is the scalp typhus disease. It is one of the differential diagnoses to be considered in a child presenting with acute undifferentiated fever. So it should be keep in mind, not only adult, child might be affected through this type of symptoms, this type of agents. A painless scar, enlarged liver or spleen, and thrombocytopenia are pointers towards the possibility of scalp typhus. These patients may be presented with a painless scar in hepatomegaly or splenomegaly or thrombocytopenia. So from the thrombocytopenia or the hepatomegaly or splenomegaly, you may suspect the other diseases that's like malaria or dengue. But when you found the painless scar, you suspected cases transformed to the probable case. Your suspicion will be more specific towards the scalp typhus. Then you have to must do the test within few hours, and without getting the result, you may start the treatment in that cases. You should not wait for the result. You must start the treatment before the getting the result if you found the such type of scar and suspected features of the scalp typhus. If scalp typhus is endemic to the locality, it is important to search for an scar, especially in the fold of axilla, neck and groin. And I have already told, oephoric test has poor sensitivity. Scalp typhus IgM by ELISA is useful for confirmatory diagnosis, but it's not the confirmatory actually. For the screening purpose, for the confirmatory, you can use the immunofluorescence assay. But it has a limit. You have to use the diagnostic procedure after 7 days. After 7 days, it shows the positivity result, but within 7 days, you have to use a PCR. The treatment options are doxycycline in case of adult 100 mg twice daily for 7 days. Alternative options are azithromycin or chloramphenicol. So that's all for today about the scalp typhus. You have to go through the scalp typhus seriously because the disease is very much endemic in the Bankura, and so many cases are being reported in the last 1 or 2 years. So thank you all. That's all for the scalp typhus for today, and I'm ending the session for today. And good day and stay safe.